were and how restrictive some of those measures were at the time. And then if we think to November, and when several countries in the European region were seeing very rapid increases, and the measures that were put in place in November, they did in fact bring down transmission extremely well. If you look at countries like France and other countries in Western Europe, transmission rates were changed very, very significantly by the measures that were put into place. In terms of the specific measures, it's difficult to say, and it's difficult to disentangle the impact of one measure versus another. However, there are some basic principles. And what works is basically anything that brings down the number of face-to-face contacts between people, and anything that brings down those specific environments, those contexts where transmission occurs. We may not be able to prevent transmission from happening, but we can certainly prevent those circumstances where transmission occurs rapidly. And that's crowding, that's confined settings, and it's closed environments where people come together. And then the third piece that I would then highlight is critical here, and that's in preventing outbreaks and measures that prevent outbreaks in particular vulnerable groups, such as long-term care settings, in prisons. These can, and mass gatherings, of course, and these can very much inflame and drive transmission in other settings. So rather than focus on the measures per se, it's really the principles behind why those measures are effective that we need to be focusing on. Thanks.
Thanks very much, Katie. Katie, I'm going to keep you on the seat, if I may. There's a question from John Goranitis, Inside Story from Greece. Thank you for taking my question. Some countries, including Greece, are performing less RT-PCR tests and have switched over to rapid antigen tests. What is your comment regarding that strategy, given that the European Commission recommends the use of antigen tests on people already showing symptoms, as the rapid kits are less accurate in detecting the virus in asymptomatic cases? Is it correct to estimate the positivity rate by combining the results from both RT-PCR and antigen test results? Katie, please.
Thank you, John. That's a great question. First of all, RT-PCR, the molecular testing that is conducted, remains the gold standard for identifying COVID-19 in patients. And it's true that it will pick up more infections. It's more sensitive. It will pick up people that are infected over a longer period of time during their infection. Having said that, antigen detecting RDTs are cheap, they're fast, they're easier to use, and they can and should be used not to replace PCR testing per se, but in complement to that. And particularly, they should be used where the virus is known to be circulating. And WHO has very specific guidance for that. The best performance for the rapid diagnostic tests that identify antigens are indeed in patients with a higher viral load, and that's particularly in early symptomatic patients. WHO and ECDC, as you say, have issued guidance, and our guidance is aligned. And in terms of defining positivity rates, these need to be set based on the case definitions. And WHO has recently updated its case definitions for COVID-19 to include antigen detecting RDTs. And those case definitions should then be used to determine positivity rates. Thank you.
Thanks very much, Katie. So, back to our journalists online. Forgive my pronunciation, Cataldo. I'm going over now to Cataldo Chicolela.
Yes.
From RAI. Cataldo, please.
Yes, thank you. So, Dr. Kluge, it has been said to us that the WHO Europe made the decision to pull the report in Italy based on inaccuracies. However, emails from Guerra and you make it very clear that the decision was political because the Italians were disappointed and surprised. What were the political considerations that went into that decision to pull the report, and why did you feel that spiking it entirely was the solution?
Thank you, Cataldo. And let me first and foremost say that I tremendously appreciate the working relation we have with the colleagues, the Ministry of Health, the people, the healthcare workers in Italy. And you may remember, Cataldo, that in fact I was the first one in as early as February who went down to Rome, and I had invited even the European Commissioner, the Director of ECDC, from the very beginning to stand with Italy, and my condolences to all the communities in Italy, country very close to our heart, who has suffered and had people seeing passed away, and my respect for all the frontline workers. So I want to make this really clear. In fact, yes, we distributed a press statement, no Cataldo, to clarify this, and everything there is, we stand by. So it's true, there was in a particular box, a timeline with a particular country also, where there's something we had to be corrected, and we put it down. I want to make it clear, like I told in the press statement, that at no any time I had any pressure, or WHO had any pressure from the Italian ministry or anyone else to pull down the report. And then there was another process in WHO, which is called interaction review, which took over. So in that sense, there were no any political consideration from my side, but you have to understand, please, Cataldo, that it's true if WHO does an assessment in a particular country, that according to our procedures, we share the report with our main partner, which is the Ministry of Health, not to have any censure or to correct, but to see whether there are any factual mistakes. And this is something that did not happen. So in that sense, this is something that was overlooked and then was being planned, but then taken over by another process. But there were no any political consideration that I can reassure you. Grazie.
Thank you, Regional Director. Next, I'm going to go to Reuters. John Miller. John, can you hear us?
Yeah, thanks for taking my question.
John.
Can you please tell me how the WHO European region is participating in work to clear hurdles for the scientific mission to China? And are you growing concern that maybe political considerations might be playing a role and interfere in finding the origins of the virus?
I think that question's probably best put to headquarters, but I'm going to ask Katie if she wants to add any points on this above and beyond what's already been said in the headquarters press briefings. Katie?
Thanks, Rob. And John, I think both the Director General and Dr. Mike Ryan have been very clear that the mission remains a priority for WHO, and I have nothing else to add at this stage. It's very much a headquarters question. Thank you.
Okay, thanks very much, Katie. I'm going to go to Associated Press, Nicole Winfield. Nicole.
Thank you for taking my question. I'd like to return, if I may, to the issue of the Italy report. There's an email that has been made public in which Dr. Ranieri Guerra appears to be asking Dr. Francesco Zambon to falsify the date, to change the date of Italy's influenza pandemic plan. I'm wondering if you consider that undue pressure to falsify research, and what policies WHO has to make sure that that type of pressure doesn't influence UN research.
Thanks very much, Nicole. Again, this is a correspondence that we're unfamiliar with or not privy to, so I would again refer that question to our headquarters colleagues, where, of course, Dr. Guerra is an ADG, an Assistant Director General, based at headquarters. So I'd refer that question to headquarters in this particular case. So I'm going to move on. Thank you for the question. I'm going to move on to Konstantinos Davanis, who's an EU correspondent in Strasbourg, the Hellenic Public Television ERT. And Siddhartha, this is for you, I believe. All countries need more and more vaccine, but production capacities are still low. You have seen, as WHO, many different vaccinations over the last few decades in different countries, and transport logistics have always been very important. Based on your experience, can you tell us how many % of doses of the vaccines could be lost because of logistical or delivery problems or delays, and especially with the very sensitive ones? Siddhartha, did you get that?
Yeah, thank you so much. Thank you, Konstantinos, for that very important question. You have heard the regional directors say a point on that having vaccine in itself is not the end of a problem. Vaccination will have a big bearing. And within that process, let me try to answer your question in two different parts. Handling vaccine and its associated logistics is an important component to make sure that the vaccine reaches to the end point or the beneficiary for which this vaccine is deemed for. When you talked about the different experiences on WHO's campaign, we have seen that. And these issues about the wastage of the vaccine is very context specific. It also depends upon the vaccine characteristics, meaning if there is any time limit beyond which a vaccine vial cannot be used, or if there are multiple doses in a vaccine vis-a-vis a single vaccine vial dose. So all these factors play a big role in terms of the programmatic elements when we talk about the vaccine wastage. The other part of this entire discussion is around how efficiently a session is being planned so that the beneficiaries who can receive the number of vaccines from a vial dose are present so that there is no wastage beyond the time limit for which a vaccine vial is scheduled to be used. However, let us not forget about this, that whether we have a vaccine recipient, and we should not wait to consider that we cannot use the vaccine because the other recipients are not around. These program efficiencies are part of what the regional director was mentioning, end-to-end support, which WHO, along with other member states, are working on. These are all programmatic considerations which will play a big role in making sure the vaccine is used effectively. You talked about the logistics and delivery. We also are working with our member states to ensure that this logistical delay doesn't allow the vaccine to be wasted. These are precious elements at this point of time when the demand for vaccine is not commensurate to the supply. We have to make sure that all these factors are taken into considerations while planning for and implementation of the vaccination. Thank you.
Thank you very much, Siddhartha. And Konstantinos has a second question, which I'm also now going to pose to Katie. So Konstantinos is the EU correspondent, Katie, in Strasbourg for the Hellenic Public Television, ERT. It has been stressed several times in recent days that the coronavirus will not be able to be eradicated with vaccinations, which will protect us for a while, but will eventually become endemic. What does it mean for humanity that the coronavirus will become endemic? Will vaccines offer only short-term protection? Should we go on a lockdown in the future, and despite the immunity, depending on each epidemiological picture of each country? Katie, please.
Thanks, Konstantinos. Again, another really good question, and we cannot predict with any certainty what will happen in the future. Eradication of any disease is a huge endeavor. Has only been achieved once for a human disease, so smallpox, indeed through vaccination, but huge differences between that disease and COVID-19. This virus has emerged, it's spread globally, and has adapted very well to circulation among humans, and continues to adapt and will continue to adapt. We still need to know a lot about how long the vaccine will produce immunity in humans. We still need to know a lot, and we can't predict how the virus itself will continue to change once more pressure is applied on it, and the vaccine will certainly do that. And we also need to further understand how well people will sign up to the idea of getting vaccinated and seek vaccination. All of these things are going to have a very big impact on what public health and social measures will still be required in the future. But I have to say that at the moment, we are very much in the thick of it. Not only are we in the thick of it, we are probably in the European region in the most acute phase of transmission. And we continue to see really big impact on our hospital wards. And in order to start to change any of that, we really need to bring down transmission and we need to control spread, despite the early rollout of vaccinations. As the regional director said, the first thing that the vaccination rollout will change will not be transmission, but it will be that the most vulnerable people, the ones that we're vaccinating first, won't go on to have severe disease and won't end up in hospital and won't die. That is the first. That is the first impact, but that's not safe to assume will happen on its own. We still need to continue everything that we have been doing, at least for the next 6 months. And this is the truth. We need to continue. We need to reinforce the virus is getting better. It's shown that it can change, and it can change in getting better at what it already does. And we need to do that too. Thank you.
Thank you very much, Katie, and thank you to Monica for the questions. Excuse me. Thank you to Konstantinos for the questions. Okay, we're going to go over to the Washington Post now. Michael Birnbaum has given us a question in the chat, which reads, you've previously urged countries to try to avoid closing schools as much as possible. Does the new UK mutation change that recommendation? Do countries need to reevaluate decisions to maintain in-person schooling? Katie, can I ask you that question? Did you get that question?
I did, Rob, and I'm very happy to start. So the principle for schools has not changed. The schools should be the last to close and the first to open. We value education in our children, and we know that the damage that closing physical schools will have, especially in younger children. And as much as possible, we hope that schools can remain open. Whether or not there is a variant in the discussion, the question is centrally around transmission dynamics. The school will reflect community transmission. Therefore, if there is a need to close schools as part of a range of measures in order to bring down transmission, that still needs to be on the table. In the case of the UK, what we saw was that as the emergence of this new variant was being detected and slowly spreading from low-level circulation into a situation where it was beginning to replace other variants and other lineages that were already circulating, the transmission context was one where there was more or less a lockdown in place in the southeast of England at the time, but schools remained open. So that meant that in the initial phases of the emergence of this new variant, that schools were more exposed to the virus. People, and that's why we saw an initial bias towards school children or younger age groups being affected. This has corrected itself in due course. So the impact of a variant actually changes very little. It's all about transmission dynamics and how to control it.
Thanks very much, Katie. So next, I have two questions to the Regional Director from Monika Kovacic, who's a freelance TV science journalist working for German TV, ARD, ARTE, ZDF. As European countries have different infection rates and different strategies in defending the corona pandemic, there is a risk of ping-pong effect. Countries with lower infection rates are endangered by countries with higher infection rates. What does WHO recommend to avoid that? I have a second question, but we'll stop there, Hans. If I may ask you, Regional Director, to respond first.
Yes, thanks, Monika. So it comes back to the principle that no one is safe or no one is protected until everyone is protected and safe. And it comes back also to the issue, and we saw an evolution there, of what we call regional policy coherence. That's a very important one, and we saw that this was a bit tough and rusty in the beginning, but there is a good evolution in the WHO European region. And it includes issues of sharing access once and if there is of COVID vaccines, and also what I would call to move towards portability of test results so that different countries recognize the test results and other issues. I think this will be a very big stress test to the solidarity, because everyone still remembers the lack of solidarity in the beginning when there was a shortage of personal protective equipment, etc. And now we come to this of the COVID-19 vaccine. And obviously WHO keeps promoting this, but not only promoting, is working with all countries on this solidarity issue. But it will be a test for all of us, and particularly for the richer countries, that ultimately all people who need the COVID-19 vaccine will get it. Thank you.
There's a second question from Monica here for you, Regional Director. What are the most important goals and recommendations of the WHO in defending the corona pandemic in Europe since the beginning of the pandemic until today? I think you partly answered that already. Would you like to add any other points?
Maybe to repeat, Monica and Rob, indeed, I was mentioning about on the health system side, the importance of the primary healthcare and the public health. And here, as a WHO European Regional Office, we're going to take a roadmap to our governing body board in September to the 53 countries on reinventing primary healthcare and public health based on the lessons of the COVID-19 pandemic. And then I was also mentioning about this initial tension between life and livelihoods, that is not one against the other. But we keep listening to the countries. What do they think that could have been done differently for the future? And there I would say no one got it right from the very beginning. And that's why I don't believe in finger pointing and hard benchmarking. We have to, in a very modest way, learn the lessons to do better, because remember what Dr. Tedros told just before the festive season, that this is not the last pandemic. By 2040, 70% of the world population will live in big cities, and about 70% of new infections are zoonotic, on the interaction between animals and human beings. And that's why the Monti Commission has established also a working group on One Health. Thank you.
Right, so I'm trying to get through a long list of questions that we've received today. I can see we're probably not going to make it before the top of the hour. So I've kind of bulked 4 of the questions here, and I'm going to put this to you, Siddhartha, and it regards, I'll try and sort of capture this. Could WHO Europe provide information about tracking which countries in Europe have begun vaccinations against SARS-CoV-2 virus, and how many doses in each country have been administered? Siddhartha, can you add something that, to that question, or respond to that question? Thank you.
Thank you so much, Rob. Yes, so we are very much aware of the vaccination rollout happening in few countries of the WHO European region. And at this point of time, we are planning for 2 different facets of tracking the doses being provided by the countries. We do understand that there is heightened awareness or need on the number of doses to be provided. So there is a mechanism being put together with our European Commission and the European CDC for monitoring the weekly doses of the COVID-19 vaccines being provided. We really appreciate that gesture, and we really are working very closely with the European Commission on that. However, as we talk about the number of doses, having a knowledge about only the number of doses of vaccines being provided is not the end of the monitoring and evaluation which WHO envisages. This involves the entire issue around vaccine safety monitoring, monitoring of the vaccine supplies linked to the vaccine effectiveness, and also going beyond that on the demand and acceptance of the population at large. So as we are talking about the number of vaccine doses being administered, it's extremely critical that we understand that monitoring of the COVID-19 vaccination is much further and beyond only enumerating the number of doses. However, these elements will take time for the countries to report to, but we also urge countries to share this information both between the countries so that we can learn from the early starters as other countries are getting prepared for. So this wider monitoring and evaluation framework will capture the different elements of COVID-19 vaccination. Thank you.
Okay, thanks very much, Siddhartha. I'm going to try and take two more questions. So the first, Tom Magner from Carers World. Tom, thanks for joining us, and I appreciate your question in the chat. I'll read it out. Throughout the ongoing pandemic, governments have rightly praised the monumental continuing efforts of frontline health and social staff, but they persistently fail even to acknowledge the equal dedicated effort of unpaid carers looking after a friend or relative, often 24 hours a day. What is the WHO's assessment of the long-term mental toll on unpaid carers of this lack of recognition, support, and low priority on getting the COVID-19 vaccine? I'll pass that over to our regional director.
Right. Absolutely. Informal health and social carers, in fact, are the largest workforce in that field. But the point here is that WHO has been advocating for the informal carers long before the COVID-19. In fact, it's one of the 8 priority actions in the European Action Plan on Healthy Aging. And I want to take this opportunity to express my most sincere appreciation to this huge informal workforce. About two-thirds are women, daughters-in-law, spouses, partners, often vulnerable themselves to health issues. So we will continue. We don't have concrete data as yet, but we'll be looking at that one. I will continue to advocate financial support, which several countries, by the way, are doing under different strategies, but also moral support, training, flexibility in working conditions, all in line with the European Action Plan on Healthy Aging. Thank you.
Thanks very much. So we have a couple of minutes left. Jürgen Cherry from Net News Malta. Jürgen, please.
Good morning. Can you hear me?
We can. Please go ahead, Jürgen.
Yes, thank you. As the regional director mentioned earlier, some member states may face a problem where the amount of people infected and vaccinations may not be agreeable with each other, where people infected will be too high for vaccinations to start working. Does the regional director suggest any rates or a specific pace that the vaccinations should be doled out in order to avoid this circumstance? Thank you.
I think that's a question maybe best put to Siddhartha and Katie. So I'm going to go to Siddhartha, if I may, in terms of the vaccination, this question, how it relates to vaccination programs and schedules.
Thank you so much, Rob. Thank you, Jürgen, for asking that important question. So let me place the facts first. The immunization system or the health system in different countries of the in all the 53 member states in the WHO European region varies widely. And I think it is extremely important that these immunization system characteristics or the health system characteristics of the different member states are integral part of the vaccination strategy for COVID-19 rollout and deployment. Because it's not one size fits all that all countries will have a strategy which is exactly the same. And hence, it's important that all the different programmatic strategic parameters are put in place in countries before the vaccine is being rolled out. It's extremely important that these preparedness are done quite robust in all the countries. WHO has learned from the data that has been submitted by 41 of the 53 member states, at least at this point of time, of the robustness in the preparedness of the different programmatic elements. So I think it is not a matter of race that which country is moving fast or which country is moving slow. It's a matter of ensuring that systems are in place, number one. Number two, that adequate monitoring is being done in the countries on the use of the vaccine. It will really be not fair for the vaccine to sit somewhere and not being used. But for doing that, this preparedness will be extremely critical moving forward. Thank you.
Katie, do you have any points that you wish to add?
Yes, I do. Thanks, Rob. And just to add, at the moment, there's no recommendation from WHO that vaccination rollout should be delayed due to high rates of transmission. Having said that, it is still the main objective for countries to bring down high levels of transmission. We are seeing extremely high levels of transmission continuing across certain countries in Europe, and we do need to bring these things down, but we can't use that as there's no reason to delay vaccination. WHO has very clear guidance to allow countries to adjust their public health and social measures based on the transmission scenarios. That includes hospitalization rates, that includes positivity, and includes notification rates for cases and mortality. Countries should look at those and look at the measures that they need to put in place, and they should roll out vaccination at the same time. At the same time, WHO is also issuing a whole set of recommendations on how to vaccinate safely, the infection prevention and control measures that vaccinators would need to take. So there's very significant levels of caution that, of course, need to be put in place. Thank you.
Thanks very much indeed, Katie. So I'm going to bring this press briefing to a close today. We've gone through the top of the hour. My apologies to Stefano, Angela. I didn't get to your questions. Please do send them in to us. We'd be very happy to respond, or, of course, respond at the next opportunity. Thanks to everybody that's called in, to all the press today and others viewing this. We'll be sharing the Regional Director's statement and, of course, posting a recording of the briefing online very soon. I'd like to just thank the panel members, the Regional Director, Dr. Katie Smallwood, Dr. Siddhartha Datta, for serving on the panel today, and please do contact us by email if there are any other follow-up questions. As always, stay healthy, take care of yourselves, and we look forward to seeing you next time. Thanks very much.